So let's make some broad general statements about the whiteboard relative to patient education. What's so important about this whiteboard and what does it do? Well, the first thing is 55% of all communication is visual. That's the most important thing. So you want to use as much visual as possible. That's a key. Now, another key concept, people say, well, you know, it's a whiteboard and it's handwritten, and I've had people say, well, how about if I turn this over and had it, you know, pretty it up and put it to a printing company and make it look nice? And I say, no, don't do that. As soon as you make it look commercialized, the trust goes down. You do not want it to look commercialized. You don't want it to look pretty in commercial. You know what I mean when I say commercialized, it's all pretty. That affects the trust. This is real. This is human. That's why it's handwritten, and that's why you don't see commercialized versions of this or that, okay? So that's another key point. Now, another thing about the board that's huge, important-wise, I can engage the patient, see? And you have to engage the patient. In other words, I can bring you on this journey. There's techniques to bring you along, because you cannot just talk at a patient. They have to understand all the concepts, and I call them micro steps. You have to have agreements in all the micro steps all the way along. And you can do that with interacting with the patients. You can't do that by them just watching a video. They don't have to participate at all if they just watch a video, okay? So you definitely want to learn and know how to do engagement techniques, and we're going to cover that. Another thing is we have it up here, and you want it on the board, but basically what we have is at the top we have inflammation, repair, remodel. Okay, that sets the tone. And you have to remember, most of us are used to being on the board, especially depending on when you went to school, whether it was a chalkboard or whatever. We're used to kind of this dynamic of interaction and learning. But this is what it looks like, and then over here it has the 4 negative aspects of the repair phase of healing. So we got increased nerve sensitivity, increase in the nerves that are trapped. We have then number 3 is 70% is strong, 70% is mobility. And what we do here is we want to put the 2 nerve components first, because we're going to talk about that first. And the reason we do is because the patient is more interested in getting relief from the pain in the beginning of the relationship, okay? So that's why we always do the nerve first. The collagen part, the strength and elasticity of the collagen, 3 and 4, that's why we'll do that on day 3, not day 2. But that's why it's in that order, okay? And then over here, you can see it says primary ADL, therapy, permanent. And these are just reminders. These are just reminders and guidelines for the doctor to go, okay, we're talking about the 3 phases of healing. We're going to talk about this particular one, and we're just going to go left to right. So it's a very easy way for to just kind of get you to remember what to say. That's what it does. Because all I'm going to do is I'm going to take the patient's name. I'm going to take the 3 most important things I'm going to do with patient education is make sure I use the patient's first name. I'm going to make sure I use their primary chief complaint and their primary ADL. That personalizes it. I'm going to plug it into the 3 phases of healing. Remember, if you just talk to them about the 3 phases of healing, it's not personal. And it has to be personal. And how you make it personal is by using their name, their primary complaint, and their primary ADL. That's how you personalize it. Okay? So, and then we'll just go left to right. So this says primary ADL therapy. Primary ADL is the one that they're having problems with. That's the one they want to get back to normal the fastest. That's most important to them. That's what that is. The therapy is the logic, because remember, this is based on the 3 major components of motivation: pleasure, logic, fear. Pleasure, logic, fear. Fear's pain. And remember, over 80% of why we'll do something is to move away from pain. It's not to go toward pleasure. So the strongest motivation is not the pleasure, getting back to what they want to do. The strongest motivation is the pain, the fear of what's going to happen if it doesn't. So this is just a reminder. Primary ADL, therapy is the logic. This is how we're going to solve the problem. And then we remind of the consequences. What happens when we injure ourselves and it heals permanently wrong? We have a permanent injury. Pleasure, logic, fear. And then that's what this is, left to right. And then down here, and you can see I marked it off here. There's a line here and a line here. That visually helps separate out boxes. If that wasn't here, it would look like one unit. And these are separate categories. So we separate, that's why there's a line to draw this up. It helps to visually separate categories is what that does. And over here, I just put the word normal. That's just another little visual clue. Part of the visual clue, when we go through the patient education, one of the main questions that we're going to ask, that's where that comes in. That's a visual clue. So again, you can add whatever you want to the board. So if you're forgetting something, add it to the board to help you to stop from forgetting. If you need to write more, write more. If you need to expand it, expand it. Do what you need to do on the board for you to remember to cover the information. Okay? And then the bottom left-hand side here, we have the bowel markers. The bowel markers we want to start with are symptoms, tenderness, nerves, and joints. Again, because the patient is more symptom-oriented in the beginning, so we're going to talk about that first. And then we use the analogy. Right here is the analogy. So we use the mop and arthritis analogy, and we talk about that. And we talk about the importance of a story. That's a story. People remember stories more than anything. Story is very important. And then this is day 3, bowel markers, range of motion, muscle, disc, x-ray. So remember, if you have another bowel marker that you routinely use, just add it in here. If you're doing a blood test, add it in here. If you're doing any other type, if you're doing any type of like structural, if you're in chiropractic bowel physics and there's something structurally you evaluate, just add the bowel marker in here. Whatever bowel markers that you use that feel important relative to your diagnostic and your therapeutic protocol, add it in here, okay? And then separate them out equally. And that's all we did here. And so the story for day 3 is concrete and permanent injury. We cover how to talk about the story. So this is kind of like a big picture of the whiteboard. And by the way, you want a big whiteboard. This is 3 foot by 4 foot. You want the biggest whiteboard down at Office Depot. It's a dry erase board. You want a dry erase board, okay? You want big, okay? And you want them in every room you're interacting with patients. Every room you're interacting with patients. So you can interact. And we leave this up. We leave this up. A lot of times I'm just up here pointing to the patient, depending on what day they are in. I'm just up here pointing to what I'm talking about. And we learn to talk about it quickly and succinctly. It happens relatively quickly. So we got the big whiteboard, goes in every room you're interacting with the patients. We got the big picture up front, 3 phases of healing. We got the 4 negative aspects that everybody's got to worry about relative to healing. That's what causes pain, restrictions, nerve sensitivity, nerves trapped, strength, mobility, more pain and decreased mobility. And then this is the formula. This is the formula of the motivation. People, you don't have to scare anybody into anything. All you got to do is tell them the truth. You're going to try to get them back to where they want to go. This is the therapy we're going to use to do it. That's very specific for whichever one of these categories we're talking about. And if it doesn't happen, these are the potential negative consequences. And we already know that it's a permanent injury to some degree. And that's how you do it. It's pleasure, logic, fear. And people will naturally pick. They'll move away from fear to pick pleasure if the obstacles are handled okay. In other words, if the big obstacles are time and money. So if they now know that you're not going to come in and waste all their time, you're efficient with their time, you don't make them wait out there forever, and when they do come in, they get treated efficiently. So they now know that you're efficient with time. And then all you have to do is break down the money to where the money's affordable. That's called terms. And so when you establish the need, you minimize the obstacles of time and go to terms, minimizing the obstacle of money. That's when everybody goes, yeah, that makes sense. Count me in. And that's exactly what happens. And this is how you'll easily get 70 to 80% of the people to go, yeah, that makes sense. I agree with you. This is a problem. It's my major problem. I do want to get it back. I do want to preferably not have it end up a permanent injury. I can see you know what you're talking about. I can see there's 3 phases. These are all the tests. And by the way, one of the biggest things about the patient education is that it's all based on these tests. You never want it based on anything you say. So it's all based on these tests. And we want the patient to understand that this is where they put all their trust, not on what we say. It's based on their tests, their range of motion, their x-rays, their nerve. That's what determines somebody's health care relative to which phase of healing they're in. And if they still have these tests and they're done with the 3 phases of healing, they end up with a permanent injury. And that's what happens. That's how it happens. And if we can treat them in each phase, in the inflammatory phase, we will have inflammatory biomarkers. We should have anti-inflammatory therapeutics. In the repair phase, generally speaking, I'll just share with you, the goal in the inflammatory phase is to decrease pain and inflammation with your therapies. The goal in the repair phase is to continue on with decreasing pain and inflammation, but now it's to increase passive range of motion. That's the goal in the repair phase. The goal in the remodel phase is all of the previous plus now increase active range of motion and elasticity. So your therapeutics will show pain and inflammation. You should have therapies to help decrease the pain and inflammation and quantify them. As they're progressing, your therapies progress into active therapies, passive therapies, plus affecting the muscles and pain. That's the therapeutic protocol in the repair phase. And then from the repair phase, they move in the remodel phase. Now they have less pain and inflammation. They have more passive range of motion. Now we go into tissue strength and elasticity. Now we work on the collagen. And that's to increase their strength and elasticity and prevent the likelihood of re-injury or permanent injury. And that's the therapeutic protocol. That's what it's based on. What are their tests? Which phase are they in? And that's what you should be applying. And of course, you quantify that. Every biomarker you quantify because it tells you if they're getting better, worse, same. Do you need to change the therapy, modify the therapy, increase or decrease the frequency of the therapy, maybe even refer them out. That's what all these biomarkers are about and the quantification's about. And of course, you do the re-exams every 12 visits. That tells you if what path the patient's on. And every re-exam, you determine if you need to shift them into another phase of care, which is another type of therapeutic protocol. Are they ready for that now? And that's how that works. So this is how it's all explained. This is all real simple. This is the whiteboard. This is typically how it's laid out. It's all designed to make it simple for the patient to see, make it simple for you to interact with the patient, and to understand in very simplistic terms, what their care is based on and why is it based on that. So if you need to add anything to it, or you need to change a word, go ahead and do it. But this is kind of the principle of how it works and why.